É desse jeito, é desse jeito. Só leva chifre quem não faz amor direito. É desse jeito, é desse jeito. Só leva chifre quem não faz amor direito. Só leva chifre quem não faz amor.
Hi, and let's talk about NIDDCP, IDSP, ICDS. A lot of alphabets all together. So all these programs are very close to my heart because these are the field level programs. So let's go to the field and let's enjoy these national health programs. Let's first talk about the National Iodine Deficiency Disorder Control Program. It is one of the most happiest program. Why happy? Because look at the logo. See how cute that smiley is. It's a laughing program. It's a smiling program. National Iodine Deficiency Disorder Control Program started way back in 1962 as the National Goiter Control Program, which was further renamed in 1986 as the NIDDCP, National Iodine Deficiency Disorder Control Program. So let's just talk about what is the TSOM in this program. T stands for the targets of the program. We will also look about the strategy from the program perspective. We will look a little bit about the organization of the program, and lastly about the monitoring and evaluation techniques. Most of the health programs, I think we have done the same thing: target, strategy, organization, and monitoring evaluation. Let's talk about the target of the program. The target of the program is to have less than 5% prevalence of the iodine deficiency disorder. Less than 5% prevalence of iodine deficiency disorder in child. Which child? According to the program, the child is 10 to 14 years of age. The program also tries to have less than 10% iodine deficiency disorder prevalence in all age group in the community. So in the community, less than 10%, please remember that is the main prima facie focus of the program. Less than 10%, any iodine deficiency related disorder. So if you were the program director, how would you do that? How would you decrease the iodine deficiency prevalence in the community? You would decrease the iodine deficiency prevalence by installing some strategies. What is the strategy you have? The only thing that you can do is iodization of salt. Iodization of salt is the only thing that you can do. MCQs on iodization of salt. How much iodine you are going to add? First is what type of iodine you are going to add. Potassium iodate or potassium iodide is added depending on the different manufacturers. We are very thankful to the Tata Salt who had taken this iodine deficiency as a aggressive mission, and they have given iodized salt to the whole country. So the potassium iodide or the potassium iodide can be added at the manufacturer level. At the manufacturer level, we want that iodine should be at least more than 30 parts per million. Why? Because if you remember from your chemistry, sorry to take you back so long years ago, but if you remember from your chemistry, iodine is a halogen group. Chloride, fluoride, bromide, iodide, they all fly, they all volatile, they all go away. So they evaporate. So if the salt is there and if you iodize it, and by the time the salt, you're not living at this place of production, right? So from the place of production, it has to go down, it will go to retail shops and then will come to you. So by the time it comes, the iodine definitely drops. So at the user level or at the consumer level, we want that at least 15 parts of per million should persist. To have 15 parts of per million in your house, we ensure that at the production level, it should be 30 parts per million. And that's the reason we say that never keep salt open in your house. If you're keeping salt open in your house for more than 6 months, then you are probably eating a iodine deficient salt. So we try to maintain that iodine status in your salt. Please remember it is 15 and 30. This could be your technically strong MCQs. Next is what is the organization of the program. Nothing very special. I have said it all the time that the organization of the program is nothing but the district level organization. At every district, you have a DGCs. What is DGC? District Goiter Control Cell. District Goiter Control Cell. So sometime they can ask you one question on this, that what does the District Goiter Control Cell do it all the time? So what they do is National Iodine Deficiency Disorder Survey. They conduct a National Iodine Deficiency Disorder Survey. So they will conduct this disorder survey. So they will conduct this iodine deficiency disorder survey every year. How they conduct? They will be belonging to one particular district, common sense. In that district, they are going to choose 30 clusters. They are going to choose 30 clusters in that particular district. District is big, right? So you choose 30 clusters. So what sampling method you are using here? We are doing cluster sampling. We are doing cluster sampling. Next MCQ. So that is your MCQ number 1. Out of these 30 clusters, we will pick up, in each cluster, we will pick up not the whole cluster. From each cluster, we are going to pick up 90 children. How will you pick up those 90 children? In one cluster, there might be many thousand children, right? How will you pick up 90 children? The 90 children will be picked up based on their school enrollment ratio, or the rates, and also based on their gender. So that's a complex phenomena. That means you are supposed to pick up 90 children based on their school enrollment ratio. So what does that mean? If the school enrollment ratio in your one cluster is 80%, so that means out of 90, 80% of 90, that is 72 kids you're going to take from the school, and remaining 90 minus 72, 18 kids you're going to take out of the school. So 72 will come from the school if the school enrollment ratio is 80%. If the school enrollment ratio is 80%, you take 72 from the school and remaining 18 will be out of the school. And also you take care of the gender. So it is based on both the school enrollment ratio and the gender. So what is the gender you are going to take? You are going to take male equal to female equal. That means 18 will be 9 and 9, and 72 will be how much? 36 and 36 total. Sorry for my mathematics, but that's how it is. 36 boys, 36 girls, 9 boys, 9 girls, 18 from out of the school, 72 from within the school. That means this is a type of a complex phenomena. So this means that there is a multiphasic stratified sampling. So different stratification is there. School enrollment, it is based on the school enrollment ratio, that is called as a population proportionate to size sampling. So if you have studied biostats in sampling methods, we have already discussed PPS sampling. So population proportionate to size sampling is done for the school enrollment ratio, and gender also we are doing simple stratified. So equal number of males and females, simple stratified sampling. So that means a lot of sampling methods are there in this IDD survey. So anyways, let's take it easy. You have a district, you take 30 clusters. Once you take 30 clusters, you take 90 kids. 90 kids will be based on the school enrollment ratio and the gender. What do you mean by this school enrollment and gender? We have already discussed. Once you take 90 kids, now you are going to do what? To these 90 kids, you are going to do 3 things with them. You will ask all the kids to go to their home and ask their mummy to give the salt sample. So they bring a salt in a plastic sheet or in a paper. So you are going to check the iodine in household salt of all the kids. You are going to check iodine in household salt in all the kids. Then you are going to check for their goiter rate. Using palpation method, you are going to check for their goiter rates. Okay. And then only to 50% of the kids, only for the 50%, that is 45 kids, half from the school and half from outside the school. So in 50% of the kids, you are going to do urinary iodine excretion. You are going to do urinary iodine excretion rate. So these will become one of your monitoring evaluation indicators. So this is the job of a goiter control society or a goiter control cell, which is available at every district. Next, let us come to the monitoring and evaluation indicators. The monitoring evaluation indicators for NIDDCP could be 5 indicators. We can have something called as the goiter rate, or we can have something called as the urinary iodine excretion rate. Third is iodine in household salt. Then we can have neonatal hypothyroidism rates, or we can have directly the cretinism rates, of course, which is one of the bad things. Cretinism rates should never be happening in the country. MCQ, which of the following is the most important epidemiological indicator, also called as the impact indicator? That is urinary iodine excretion. It is the most important indicator. It is the epidemiological indicator. It is also called as the impact indicator. But goiter rate is what you are checking. So finally, at the end of the day, you also want the goiter rate. That is the target of the program. But this is called as the chronic impact indicator or the long-term impact indicator. Goiter rate is also one of the impact indicator, but it is a very long-term impact indicator because goiter, common sense, doesn't change every year. But iodine excretion can change very fast. So urinary iodine excretion becomes one of the most important epidemiological indicator called as the impact indicator or the most important indicator. Iodine in household salt. Iodization of salt, that was the strategy. That is called as the operational indicator, or under this program, we are naming it as a process indicator. It tells you how good the process is. Right? Neonatal hypothyroidism it's a tricky MCQ. It's a tricky evaluation protocol. Neonatal hypothyroidism. How do we get the data from neonatal hypothyroidism? We get the data from the hospitals, from the it's a secondary controlled data. So it's a very sensitive parameter for assessment of how the program is doing. Is it bringing out change in reality in the community? So urinary iodine excretion is done by the goiter control cell. That is done by us only. So, but this secondary data is are you getting the impact in the area? So anyways, all said and done, let's keep it simple for your exam. Please remember neonatal hypothyroidism rate, direct MCQ you'll get in case you get one. Neonatal hypothyroidism rates are very sensitive indicators. They are very sensitive variables or indicators for assessment of the National Iodine Deficiency Disorder Control Program at the community level. Is it finally at the end of the day helping community? What was the neonatal hypothyroidism rates in 2017, in 18, in 19 and in 20? Director NIDDCP was changed in 2018. Did we get a change after that in neonatal hypothyroidism rates? So that's how we talk in the government. So we talk about neonatal hypothyroidism all the time because it's a very sensitive indicator of assessment of the program. But the epidemiological indicator is the urinary iodine excretion because that's a daily thing that we are generating. Cretinism rates is one of the bad things. That is the final indicator. I would also like to tell you that if you talk about the urinary iodine excretion, the urinary iodine excretion in all the kids should always be, in any person, should be more than 100 micrograms per liter. When will we say that urinary iodine excretion is not appropriate? If it is 50 to 100 micrograms per liter, it is called as a mild public health problem in that area. We need to rectify it. If it is 20 to 50, that is called as moderate public health problem. PHP stands for a public health problem. So by now, if you have watched all my lectures, you must be knowing what all abbreviations I'm using. But anyways, it's always a pleasure to write them again for you. So 50 to 100 micrograms per liter is a mild, 20 to 50 is a moderate, and of course, common sense, with below 20, it's like you're doomed. It's a severe public health problem. Next day only you'll be there in the newspapers, pictures flashing that this is the director who actually stopped all these programs and this is the problem the community is facing, and so many things. Next is a couple of points about the goiter rates. The goiter rate is also an important indicator. I told you that what is the target of the program, to keep it below 5. But if it is more than 5%, it is called as a public health problem. Public health problem. If it is more than 5%. If it is 5 to 19%, it is called as a minor public health problem. If it is 20 to 30, it is called as a moderate public health problem. And if it is more than 30% prevalence of goiter in the school-going children, it is known as a severe public health problem. Currently, the whole country is either in the 5 to 19 area or it is below 5. So most part of the country is below 5, except a few districts which are having around 6 or 10 goiter rate in our country. We don't have any area which is 20 or 30 public health problem for the goiter rates. How do you check the iodine in household salts? How do you check iodine in household salts? It is done using a special kit called as MBI kit. It is done using a special kit called as MBI kit, and you'll be proud to say, I'm proud to say, and you are also, you should be proud to see that MBI kits have been produced in India. They were devised in India from Tamil Nadu. One of the very senior public health doctors devised it, and it is being approved by the WHO, and it is being used across the world. These are very simple MBI kits to detect iodine in salt, in household salt. So with that, we finish this program on National Iodine Deficiency Disorder Control Program. Next is let's talk about the Integrated Disease Surveillance Project, a project which is very close to my heart, because many aspects in preventive medicine and community medicine and public health I've learned from this. I have had the opportunity of learning from this program or the project, IDSP, Integrated Disease Surveillance Project. This project was started way back in 2004 and was finally implemented to the whole country somewhere in 2007-8. So anyways, it was started in year 2004, and it was started for 5-6 years program till 2010, and was later extended every time. So what is the objective behind this program? It is an integrated disease surveillance project. What do you mean by surveillance? Surveillance means to keep a careful watch, and in case there are some problems, you give immediate feedback for immediate rectification. So under this program, you have these three friends. Can you see these three friends? Friend number 1, friend 2, and friend number 3. They are holding each other hands. So that means they are friends, right? Of course, they have washed their hands, they have sanitized their hands, and that's the reason they are holding it. Otherwise, we would have kept a social distancing over here. So these are your three friends. You have the S, the P, and we have the L. S, the P, and the L. What do you mean by all these MCQs? S means the syndromic surveillance. L means the laboratory surveillance. P means the probable case surveillance. So you have these three friends: syndromic, probable, and laboratory. Next MCQ, who's doing what? Syndromic surveillance is done by the health workers in our community, health workers in the whole country system. The laboratory people, the lab technicians or the laboratory, private laboratories or the government laboratories, they are giving the laboratory surveillance data. The probable case surveillance data is given by the medical officers in our country. So either in rural or in hospitals, we are gathering data from these health workers. We are gathering data from the laboratory professionals and the probable to find out what is happening in the country. As the diseases increase, immediately we take rectification measures by giving that responsibility to that particular doctor or that particular group, and they are going to control that any disease which is happening in the area. So what are the diseases which are under the surveillance? The syndromic surveillance is taking care of 6 syndromes. The health workers are taking care of 6 syndromes. You have the syndrome of fever with or without localizing signs. Then you will ask for the fever of cough, the syndrome of acute flaccid paralysis, syndrome of jaundice, syndrome of diarrhea, and in any case of any unusual disease or death has to be reported by the health worker. So in case of fever with or without localizing sign, what disease are you targeting? We are targeting all the fever related diseases like malaria. It could also be disease with rash, fever and rash like measles. It can also be other vector-borne diseases like Japanese encephalitis, dengue, anywhere the fever is there. So any case of fever has to be reported to IDSP. Any case of cough, primarily we are talking of the tuberculosis, has to be reported to IDSP. Any case of acute flaccid paralysis, and primarily we are talking of poliomyelitis, has to be reported to IDSP. Jaundice, we are talking of hepatitis. We are also talking of leptospirosis. We can also have, in this case, malaria. Severe malaria can be there. Yellow fever outbreaks can be there. We don't know what is happening. So all the cases of jaundice are also being scaled up by the health workers to the IDSP. Diarrhea, per se, we are talking of cholera or acute diarrheal outbreaks in the country. Unusual disease, what are the diseases under the unusual things that we keep a watch for? We are keeping a watch for anthrax and plague. So in the country, wherever these things happen, we come to know. So that is the use of the syndromic surveillance. If you talk about the probable case surveillance, so there are a couple of lists of probable case surveillance. You have 21 diseases under it. So you don't need to memorize each disease. But in general, these are the list of diseases which are for the probable case surveillance. And on the other hand, you have around 11 to 19 diseases depending on what area we are living. So some areas will have more endemic diseases, some areas will have less endemic diseases. So depending on the area type, we are having a laboratory surveillance. But the MCQ which can be asked to you is about the syndromic, because that is a fixed syndromes which are being assessed across the pan-India. From Jammu Kashmir till Kanyakumari, Gujarat till Meghalaya, Manipur, all the diseases, Arunachal Pradesh, all the syndromes are being catered for. So you have the S form, the P form, the probable case surveillance, and the L form, that is the laboratory surveillance. All are gathered together and is presented. So every month, IDSP, it's a massive big task. Every month the IDSP gives a disease alert to the Government of India. You can also Google this website, idsp.nic.in, nic.in, and you will see dynamic maps. You will see in whole country where KFD cases started coming. So right now, while I'm talking to you, there are a couple of KFD cases, outbreaks in our country. So where there were more dengue cases. So what happens where there is a monthly report which is being given? How is the surveillance being done? Please remember it for your exam that all these surveillance, the probable, the syndromic and the laboratory, all these surveillance, these are done on, it's a surveillance project, right? These are done on 14-day basis. Every fortnight we are gathering data. Every 14 days we are gathering data and publishing on monthly basis these type of disease alerts to the Government of India. So it's a monthly surveillance report launched by the IDSP under the National Health Mission. So a new thing for you to remember from IDSP is now being scaled up. So IDSP is there, but now it has been scaled up to CBHI. What is CBHI? It is just the improvised version of IDSP. It's a next version of IDSP, that is Central Bureau of Health Investigations. So it includes more diseases and a more robust system, and the whole country is participating into CBHI. The transition is going on. Beyond IDSP, just one more point for you to remember. I know there's a lot of data which is coming on your side. You also need to remember what is IHIP. IHIP is Integrated Health Information Program. So basically, IHIP is to digitalize the health information system, panel in our country. So right now, IDSP is IDSP. IHIP is a digitalization of all the health records, but IDSP is always going to stay because it is a surveillance project, and the newer form of IDSP is CBHI. Many students get confused that maybe IDSP is now IHIP. Please understand, IHIP is something different. That is Integrated Health Information Program. It is digitalization of the health records of the citizens of our country. You will get all the records, all the like what is happening with malaria program, TB program, IDSP program, RCH program, all the programs, the data will be there. So that is what is IHIP. But IDSP is about the disease surveillance. So with that, we finish this point and topic on IDSP and CBHI. Have you seen this logo now? I think many of you must have seen this, but still many of you must not have seen this. You know all the programs, but you don't know the logo. Many of you must be surprised to find out that this is the logo for Anganwadi. This is the program for ICDS program. Let's talk about ICDS. ICDS stands for Integrated Child Development Services. Integrated Child Development Services Scheme. This ICDS program was launched on Gandhi Jayanti on October the 2nd in 1975. It's a long program. This program, ICDS program, first MCQ, is under Ministry of Women and Child Development. It is not under the Ministry of Health and Family Welfare. First MCQ. The objective of this program or the target of the program is to have a holistic development of the child. It is to have safe motherhood, and to have a healthy child for the nation. So holistic development includes the social development, very important. It includes the social component. It also includes the physical component, and it also includes the nutritional component and all the components of a development of a child. A healthy citizen of the country will be healthy if the mind is healthy, if the body is healthy. That is why we have a strong body and a smart mind, right? And that's what is going to make a healthy child. Next MCQ, what are the beneficiaries under this program? Beneficiaries under this program. So it's a very age-old program, and it has very deep roots in our country. The beneficiaries in the program are three. One is a child, second is the mother, and third is the adolescent girl. Three people are under this program. What age group child we are considering? 0 to 6 year age group. What mother are we considering? We are considering pregnant mother or lactating, or both. We have to consider both P and L, pregnant and lactating mother. And adolescent girls are basically all adolescent girls up till 19 years of age. So all girls under this program, they are under this ICDS program. Next is, what are the benefits under this ICDS program? The benefits under this ICDS are supplementary nutrition. We will give them some food to the beneficiaries. We will give to the child, to the mother, and to the malnourished child. We will give them some calorie intake, some protein intake, and there will be some cost which is associated in terms of the INR rupees. To the child, every child will get 500 calories. The mother will get 600 calories. Malnourished child will get 800 calories. If you talk about the protein component, child will be 12 to 15 grams of protein. Mother will be 15 to 20 grams of protein, and malnourished child needs more gram of protein, 20 to 25 grams of protein. Coming to the cost of the program, the child will be at the cost of 8 rupees per child. Mother will be at rate of 9.5 rupees per mother, and the malnourished will be, the upper limit is 12.5 rupees for every malnourished child. This will be the cost in terms of cost per person. So technically, this program is main focus is to give them nutrition. Other benefits could be non-formal education. So mind it, it's a non-formal education. It's not a formal education where you get a certificate graduated from Anganwadi. Nothing like that would happen. So it's a non-formal education. We just teach them basic life skills. We just teach to the child some of the basic manners which they should have. Hygienic lifestyles or sanitation and hand washing and all these things. So that is what is non-formal education, and you should greet your parents and say hello, hi to your elders and these things. Third is facilitating immunization. Please mind it, it's not that the Anganwadi worker is doing immunization. This program is under the WCD ministry. It is not under the health ministry, and therefore the Anganwadis will be facilitating immunization. They'll call the children, they'll call the ANM worker, they both will meet, they will immunize. The immunization will be conducted by the ANMs or the health workers from the community, from the health department, but they are going to facilitate for immunization. They will also promote family planning services. The Anganwadi is being trained to give basic essential healthcare. Basic healthcare or the essential healthcare in terms of giving paracetamol syrups or amoxicillin and things like this. Fifth is very important. One of the most important is adolescent health. This is an expected MCQ for you. Adolescent health is an expected MCQ. Adolescent health program or the AG scheme, adolescent girl health program, we call it as a adolescent girl scheme, AG scheme. Lately, it has been changed to Kishori Shakti Yojana. Kishori Shakti Yojana. So this all means the same. Adolescent health scheme or the adolescent girl health scheme, they all mean the same. What all things you need to remember? Under this scheme, there are many strategies. The first strategy is girl to girl approach. There is a girl to girl approach. So in the girl to girl approach, basically we are organizing workshops at district level, at state level, block level, and these all girls will be interacting with each other. Second is formation of Balika Mandal. So Balika Mandal is a group of girls who are having some leadership qualities, and these girls are going to lead other girls. So they will form Balika Mandals. So that is like group of girls getting together. So group of girls getting together, and they are going to act as the leaders of the community, so that people look forward to them. Third is another one, that is a Sabla scheme. Sabla scheme is nothing but a state-wise enabled program. Like state-wise, these programs are there based on their own cultural practices and so many things. It is for overall adolescent girl development. What does it mean? It means this Sabla scheme includes many sub-components. It will include the National Skill Development Program. National Skill Development Program, or the project. National Skill Development Project. It will also include the ARSH program, or we call it as the AFHC program. What is AFHC? Adolescent Friendly Health Clinics. Adolescent Friendly Health Clinics. It will also include the public distribution system. The public distribution system, or which we call as the wheat-based nutritional program, WBNP. What is WBNP? This can be asked to you. WBNP is wheat-based nutrition program. It is a wheat-based nutrition program giving food grains to the adolescent girls. And of course, I think we have had a lot of discussion on this in the chapter on mother and child health care, that to adolescent girls, we are also giving iron folic acid under the Anemia Mukt Bharat scheme. AMB stands for Anemia Mukt Bharat scheme. So these all are under the Sabla scheme. We have tried to have overall development of a girl child by giving them skill development, by giving them more vocational training, by taking care of their RTIs, STIs, adolescent reproductive sexual health. That is what is a ARSH program, right? So in case you don't understand the abbreviations, please look for them in the MCH. ARSH stands for, I'll write it down, Adolescent Reproductive Sexual Health. AFHC stands for Adolescent Friendly Health Clinic. So in this, basically you are targeting the RTIs, STIs, the infections, and you are taking care of their iron folic acid, the menstrual hygiene, you're giving them sanitary pads. So many things are being done under this ARSH program. Then you have the wheat-based nutrition program, where you're giving them food grains under the PDS. PDS stands for the Public Distribution System. It stands for Public Distribution System in the Government of India, those fair price shops you have. Then you have the IFA tablets. IFA stands for iron folic acid supplements under the AMB, Anemia Mukt Bharat program. So all these that you have studied are under the Adolescent Girl Kishori Shakti Yojana program, which is under this ICDS program. So ICDS has very big roots in our country. Next point is, there is also ICDS training. So every time there is ICDS training, this ICDS training, all the Anganwadis workers, they are being concurrently updated on the material. This training can be asked to you, what is the name of the training? It is called as Udisha training. The training name is Udisha training. So with that is all the strategies that you know. So after this, one of the main functions of ICDS program. What is the main function of why do you think Anganwadis are actually there in the country? They are actually there. We should not forget about this main function, that is growth monitoring. That is growth monitoring. So that is their one of the prima facie main function of the ICDS program. How do they monitor growth? They monitor growth using the ICDS growth charts. ICDS growth charts. They use the ICDS growth chart. And how do they make a growth chart? They have to weigh the baby. How do they weigh the baby? They use a Salter scale. So these are couple of MCQs you need to remember. Just let's have a look at the Salter scale. What is this? You see, it's a scale which hangs from the roof. So you can just take this as a bar in the roof, and the Salter will hang. And below this, there is a knicker kind of thing, or shorts kind of thing. So you put the baby in that shorts, and the baby is going to lie here, and this scale is going to move. MCQ over here. What is this called as? This is called as a Salter scale. Question number 2. What is the precision of the scale? What is the accuracy of the scale? The scale is for every 100 grams. You can be as accurate as up to 100 grams, because if you see the intermediate lines, I don't know if you can just zoom into your phone and see, if you see the intermediate lines, they are at 100 grams interval. So these are the MCQs you can get about Salter scale. Next you can see is the growth chart. So this is in fact a live growth chart which I had taken a picture, and you can see the upper curve, then you see the middle curve, and then you see the lower curve. MCQs on this: the upper curve, it stands at what point? It is the median of the MGRS of our reference standards. The middle curve is at -2 standard deviation, lower curve is at -3 standard deviations. So these are the three curves that we have in ICDS growth chart. How many years are plotted on this? Can you see that 1 year, 2 year, 3 year, 4 year and 5 year? This is a 5-year growth chart. We also have in some states 3-year growth chart. But then you need another 2 years for the child, because under this program we are keeping for till under 6, right? So this takes into account the first year, the second year, the third year, fourth year and fifth year age group child. So these are important things about the monitoring of the growth weight of the child. Please remember, in this growth chart, what do you think if the child is today like this and next year also, next month also it's like this, do you think a flat growth chart, is it a good sign? Answer is no. No flat growth chart should be there. Flat line is always a dead line. So the curve of the growth should always be uprising. That is what is the use of this ICDS program. So what you have actually done in this ICDS program is you have talked about the targets, you have talked about some of the strategies. And now let us talk about some of the newer strategies, and then we will talk about the organization of the program. Newer strategies. The newer things that are there under this program is something called as a Sneha Shivir. What do you mean by a Sneha Shivir? Sneha means love and affection. So it means it is a special focus. It is a special focus on what people? It is a special focus on malnourished child. What do you mean you are going to do special focus? You have to give them physical balance and you have to give them social balance. Physical balance is being given by you feed them more, and the social is being given them by taking care that they should not land up into malnutrition again. Very important. Treating a malnourishment is one thing. Preventing malnourishment again in future is a tremendous thing. That is what, with hands folded, this ICDS program is doing. Next is another strategy that you need to remember is Anganwadi Karyakarta Bima Yojana. Anganwadi Karyakarti. It's not Karyakarta, Karyakarti. Because it's a female in the Anganwadi. Karyakarti Bima Yojana. So nothing very special, and of course for the Anganwadi females it's very special. It is for insurance, health insurance scheme for the Anganwadi workers has been recently launched by the Government of India. So these are some of the newer strategies. Coming next to the organization of the program. Organization of the program, I have again discussed almost the same points in the National Health Mission chapter. Because Asha worker and Anganwadi worker, they are hand in hand. I cannot think of a village where Asha is different, Anganwadi is different, like one is absent. It's not possible. Every village to have Asha and Anganwadi, and that's what I have understood in the health system in our country. So I'm going to repeat most of the points again over here just because this chapter has to be completed. Organization of the program, Anganwadi is at the lowest level. You have an Anganwadi worker. Above the Anganwadi worker, Anganwadi worker. So that is what is the Anganwadi at the lowest platform. Then you have a Anganwadi supervisor, and above Anganwadi supervisor you have a CDPO. CDPO. What is CDPO? It's a Child Development Project Officer. Please mind it, it's not a Child Development Panchayat Officer. That is BDPO, Block Development Panchayat Officer. That is separate civics administration. In health system, we have a Child Development Project Officer. Next MCQ. What is the population protocol for all of them? Please remember, Anganwadi worker has different answers. So it ranges from 800 to 1000 population. If you get one answer, technically right answer would be 800. If you get one answer. Otherwise, in general, we are always taking 1000 for one Anganwadi. Then every supervisor has 25 Anganwadis under them. So this Anganwadi supervisor is for simple answer 25,000 population. One CDPO will have 4 supervisors under them. So 1, 2, 3 and 4. So 25, 25, 25, 25, that is 100,000. If you recall from your knowledge in civics and in public administration, you must recall that one village is for how much population? One village is for 1,000 till 2,000 population. Above village you have the panchayat system, right? So above village you have the gram panchayat. You have a gram panchayat. Gram panchayat is for 5,000 till 6,000 population. Above gram panchayat you have what? You have blocks, and above blocks you have the district. Block is for how much population? 100,000 population. That's what you need to remember. So if you understand block is for 1,000, so in one block how many CDPOs will be there? In one block you will have one CDPO. So basically CDPO works at block level. This is one of the few programs, mind it, this is not a health program. Health program is Ministry of Health and Family Welfare. This is a WCD ministry program. Under the WCD ministry program, the administration is not at a district level. In all the health programs, I always told, health program, close your eyes, answer is district administration. This is not a health program. The administration will be at block level. Next is one more point before we close off this topic, that what is a mini Anganwadi? Mini Anganwadi is for many areas which have lesser population. So it can be from 150 till 300 population, we can open one mini Anganwadi. So if you have 400, 500 population, you open 1 or 2 mini Anganwadis. Otherwise, if you get one answer, please remember one Anganwadi is for 800 population. So that closes your chapter on ICDS program as well, because in this, the monitoring and evaluation indicators is basically the same answers. That is the under 5 child mortality. You look about the malnutrition rates. You look at number of stillbirth rates in the mothers, because that is going to take care of how many iron folic acid the female is being getting, and what is the ANC care that we are giving. It's all same thing, that you want a healthy mother and a healthy child at the end of the day. So with that, we finish off this topic on ICDS, NIDDCP and discussion about the IDSP. Thank you so much for watching this module.